All right, today we're diving into a topic that sits right at the intersection of medication and real-world patient wellness, special diets. And as you're about to see, this is about way more than just what's on the plate.
As pharmacists, our whole world revolves around medication. But just think about your last shift for a second. How many times did a patient's diet directly impact the therapy you were dispensing? This whole explainer is about getting you ready for those critical conversations. So here's the game plan. We'll kick things off with why nutrition counseling is becoming a core part of our job. Then we'll get into the big one, cardiovascular health. After that, we'll cover critical med-diet interactions, and we'll wrap up with some other specialized patient needs.
Okay, let's jump into Section 1, Nutrition Counseling in Pharmacy. I want to be clear, this isn't some nice-to-have add-on anymore. It's really becoming a fundamental piece of our expanding role in patient wellness.
So here's why this really matters. The right diet can be just as powerful as a prescription. When we take a moment to counsel on nutrition, we're not just handing out lifestyle tips. No, we are directly impacting patient outcomes and, maybe most importantly, we're ensuring their safety.
Now for Section 2, we're talking about cardiovascular health. This is our bread and butter, right? We're going to focus on hypertension and dyslipidemia, two of the most common conditions we see every single day behind the counter. We have all been here. You know the scene. A patient, they look a little worried, newly diagnosed, and they're holding their very first bottle of lisinopril. They look to you, the expert, and ask, what else can I do? This is our moment. This is where we can provide some real, evidence-based guidance that goes beyond the pill.
And the very first, most high-impact piece of advice you can give them is this number. For hypertension, the guidelines recommend a target of just 2 grams of sodium per day. It's a clear, simple, actionable goal for your patient to latch onto. So where is all this sodium hiding? Well, here's the key counseling point, and it's a shocker for most patients. It's not the salt shaker on the table. A staggering 75% of the sodium in our diets comes from processed foods. So our job is to help patients spot these hidden sources and guide them back towards fresh, whole foods.
And this focus on whole foods is pretty much the foundation of the DASH diet. And this isn't some fad diet of the month. It's a seriously evidence-based approach that's all about limiting sodium and red meat, while really leaning into those nutrient-packed foods we just saw.
Okay, shifting gears to dyslipidemia. For patients struggling with their cholesterol, the biggest dietary lever they can pull is their fat intake. And the counseling message is actually a pretty simple swap. We want to reduce saturated fats, which are the single strongest contributor to high bad cholesterol, and replace them with those heart-healthy unsaturated fats.
And here are the specifics. So when your patient asks, okay, but what should I eat instead? You can point them to things like salmon, avocados, walnuts, olive oil. These are tangible, delicious examples that can make healthy eating feel a lot more achievable.
Okay, let's get into Section 3. Now, this is our turf. This is where our unique expertise as pharmacists absolutely shines. Critical medication-diet interactions. Honestly, this is the core of what we do.
First up, a massive red flag. For any patient taking an MAOI inhibitor like phenelzine or tranylcypromine, a tyramine-controlled diet isn't just a friendly suggestion. It is absolutely essential to prevent a potentially fatal hypertensive crisis.
And this is the non-negotiable list. Patients must completely avoid these foods. We're talking aged cheeses and meats, certain fermented foods like sauerkraut, fava beans, and all tap beer. This is a critical safety checklist for any MAOI counseling session.
Next up, let's talk about the delicate potassium balance. Just think about how many of your patients are on an ACE inhibitor, an ARB, or a diuretic. For them, dietary potassium is not a simple eat more bananas conversation. We have to figure out if their medication is making them hold on to or waste potassium, and then help them adjust their diet to keep things in a safe range.
Now, let's talk about gout. Sure, we dispense tons of allopurinol and colchicine, but are we telling our patients that a purine-restricted diet can reduce their risk of another one of those agonizing attacks 5-fold? I mean, that is a powerful, powerful motivator for dietary change.
And you can break this advice down into a really simple avoid, limit, encourage framework. The biggest no-goes are organ meats and high-fructose corn syrup. Then you limit things like red meat and especially beer. And instead, you encourage patients to go for low-fat dairy and plant-based proteins. It's a roadmap to fewer flare-ups.
All right, let's move to our final section where we're going to touch on some other specialized needs that you will definitely see in your practice, everything from celiac disease all the way to dysphagia.
For a patient with celiac disease, a strict gluten-free diet is their medicine.
It's non-negotiable. The key is helping them understand how to avoid the big three, that's wheat, barley, and rye, while pointing them towards safe and delicious alternatives like rice, corn, and quinoa.
And here is a fantastic pharmacy-specific pearl. We have to look beyond the active ingredient. For our highly sensitive patients with celiac or even lactose intolerance, those tiny amounts of gluten or lactose used as fillers in their multiple medications, well, they can add up and actually cause symptoms. It's our job to be the detective and check that.
Now let's talk about a major safety issue that we see all the time, particularly in long-term care or with post-stroke patients: dysphagia. For these individuals, the texture of their food and the thickness of their liquids is absolutely critical for preventing aspiration and pneumonia.
Now, we don't need to be dietitians, but we should understand the basics of what's called the IDDSI framework. Just being aware of these key levels, from totally liquidized to minced and moist, all the way to just easy to chew, helps us understand the patient's care plan and make sure that the medication formulations we dispense are appropriate and safe.
So what's the big takeaway from all this? When you boil it all down, it's this. Dietary counseling is not just some fluffy add-on. It is a powerful clinical tool. Your expertise in medication combined with this nutritional knowledge is absolutely central to providing safe, effective, and truly holistic care.
And that really leaves us with one final thought. After hearing all this, think about the patients you'll see on your next shift. What dietary conversation, even if it's a small one, will you start tomorrow?